First, I do want to say again, thank you so much for everybody coming here, especially with it pouring out. Let me know if any of you have a hard time hearing me. I do end up having a quiet voice at times, so like, please don't hesitate to like stick up a hand and be like, speak louder. I do want to say thank you to Spooner and to Carrie to letting us use this space. I do have a private practice. I am Catherine Savoia, first of all, that's my name. I own Thrive Physical Therapy. I do have a physical location. It would not fit all of you in it, so that's why we're here. I am an orthopedic and a neuro-based PT. I specialize in vestibular, concussion, all head and neck things, think upper cervical instability, TMD, all that stuff. My history is as a dancer. My undergrad was in dance. I thought I was going to treat only dancers. Now I treat all the weird stuff. So I always say when PTs are like, who are your people? I'm like, the people that you don't want to treat, those are my homies. Like the chronic pain, all the stuff that you're like, nah. That's mine. So I'm very much a holistic provider. I really try to bring in all the things that we're going to talk about today. That's why I have this small space that is a safe space for my patients. And I'm super passionate about the Trifecta, as I am also a Trifecta patient. Most patients are also providers if they were a provider before they became a patient. This is definitely an underdiagnosed population that is super appreciative for anything that you can give them information-wise or just even validation. So being here is like wonderful to be able to have this space to even talk to you. And so my patients are already so excited that I'm even speaking about this at multiple events lately. So I'm hoping that awareness will keep growing. Tonight I really hope to give you a clear understanding of what these three jargons of letters are and how to recognize them and how to just really safely start to work with these people. So let's make sure that this is moving. Is it moving up there? Okay. So why does this matter now, right? POTS and Trifecta and MCAS are not a new thing, and EDS is not a new thing, but it is very prevalent post-COVID. This study was 65 million people pre and post-COVID, and the increase in incidence of POTS increased 14-fold. So drastically, this is not a niche population anymore. This is in your clinic and you either know it or you don't. And a lot of people don't have diagnoses, so a lot of the stats that we're going to look at is off of really limited research. So take them all with a grain of salt, knowing that most of these things are probably higher numbers. Another meta-analysis found that the quality of life for POTS patients is actually comparable to MS, is the only thing that scored lower. Everything else, including like HIV, COPD, chronic kidney disease, all had a better quality of life on this survey than POTS patients. So these patients are severely debilitated and not getting the care that they need. One of the biggest things is that no specialty really owns these diagnoses, right? Dysautonomia doesn't have a specific specialist that sees them. I actually rechecked this morning. The amount of actual autonomic neurologists that exist in the world is less than 100. In the US, it's about 60-something was the number that I got today. Yeah.
Did you define what dysautonomia was?
We're getting to that.
Oh, okay. All right.
Sorry. This was more just to show you that this is a thing that's really happening that most people have no idea, right? So for context, actually, can you raise your hand if you're seeing patients that have any of these three diagnoses? Great. And then keep your hand up if you feel confident treating patients that have these diagnoses. And then raise your hand if you have no idea about any of them. Okay, perfect. Just so I have an idea where we're at. And some of this will be redundant for people that are treating these things, but I'm going to try to go as broad as I can to touch on everything that we need to talk about. So these are the objectives that you all saw with signing up to come here today, so I won't necessarily go through all of them. And let's jump right into EDS. So Ehlers-Danlos Syndrome, or EDS, or EDS, is a group of connective tissues that are or disorders of connective tissue. So there's 13 subtypes, the main one being hypermobile Ehlers-Danlos, that is HEDS, if you will. We love an acronym. So these are all characterized by joint hypermobility, skin extensibility, and tissue fragility, all 13 types. Each one has a little bit of a different flavor to them. Most of them are very rare, The big scary one that we need to be aware of is vascular EDS. Those patients are going to have issues with bleeding. They're going to have aneurysms and ruptures. Most patients that have vascular EDS know it before they get to adulthood, but it is still a thing to have on our mind. So hypermobile Ehlers-Danlos and also hypermobile spectrum disorder, we'll get into the difference and similarities of them, are the ones that you're going to see the most. So if you've had a person that has come into your office that you're like, wow, you're bendy, or your friends or yourself that has double jointed things, right? 90% of EDS cases, though, are these patients. And of the 13, all of them have a genetic actual marker that we know except for hypermobile, which is ironic, being that it is 90% of cases. The Ehlers-Danlos Society is doing a lot of research right now, so hopefully in 2026 we will have that marker. There's a lot of really exciting research in this space coming out, but definitely not fast enough. And so hypermobile spectrum disorder is the thing that we characterize people as when they don't meet all the criteria for true hypermobile Ehlers-Danlos. The criteria is very specific. It is not great criteria. It does not capture all of hypermobility. We'll talk about what that criteria is. But HSD is more common than EDS, and then we know that EDS is about 1 in 500. Remember what I said, not great research. So probably more common than that. And if you're treating pain, you're not seeing the other people. You're seeing a lot of the people that have chronic pain that have EDS. So sometimes once you start to see it, you're like, does everybody have it? And then it's like, no, it's because a lot of patients that have pain are gonna come to you and they're gonna end up being hypermobile. Let's see, it is a diagnosis of exclusion, and then it is going to be more females just because of our hormones for sure. And then symptoms can begin in adolescence. A lot of the time people have the onset in puberty specifically, but some people can go their whole life with it and have no idea until somebody else in their family has an issue. The diagnostic delay is extensive. So on average being 22 years for true hypermobile Ehlers-Danlos and around 17.5 for hypermobile spectrum disorder. That was one recent survey. So people are not getting recognized. And so if we can even just do quick screenings on somebody when you're just like slightly suspicious, hopefully some of the things that you pick up today, you'll be like, oh, maybe. And then we'll do a quick screening and you'll be like, all right, this is the thing we need to look at. These patients are different than everybody else, as much as we want to think that they're just stretchy or bendy, right? Like connective tissue is in everything. It's in all of the structures. It's in your bone, the periosteum of your bone. It's in blood vessels. It's in your nerves. It's in your dura. It's in your, like, it's in everything. So when we say, oh, you're hypermobile to a patient, that just makes them think, okay, I'm stretchy. But really when we look at some of the other things we're gonna talk about, there are so many things throughout their life that are going to be abnormal that if they just knew a little bit more about what their body is going to present as, they'd be able to do better for themselves. And some of just the diagnostic delay is the fact that if somebody walked into your office and told you they were having GI issues, maybe pelvic prolapse, they're having tissue fragility, and maybe they're having some like tachycardia, or they're having chronic pain and they have all these weird joint things happening, like, are you really going to jump to, oh, this is a connective tissue thing, right? Like you're going to see all these silos, and then they're going to see all these silos of providers that aren't going to be able to pull everything together. So one of the phrases that Ehlers-Danlos Society likes to use is, when you can't connect the issues, think connective tissues. It is a cute saying. It is helpful to remind yourself when you're like, that's a lot of things going on. Try to think of that. And then zebras are kind of the mascot for EDS, in the way that in med school most teachers will say, when you hear hoofbeats, think horses, not zebras. These are zebras. Like, these are the things that you are like, that should be rare. However, with the caveat of this isn't really rare. So that's the piece that is kind of missing at this point, that we're thinking of us as zebras, but it's a lot more common than you would think. Okay, so here is the diagnostic criteria for Ehlers-Danlos hypermobile. So the Baton scoring system, if anyone is unfamiliar, you can find all this on the Ehlers-Danlos website. So Baton is going to be based out of 9 points. If you are a youth, you only need to score a 6. If you are An adult up to the age of 50, you need to score a 5, and if you're over 50, you need to score at least a 4. So each thing is going to be pinkies past 90 degrees. It's going to be thumb to forearm, this way, not that way. So it's thumb in wrist flexion to forearm. And each one you're going to test both sides. So it'll be like a 1, 2, 3, 4, elbows, 5, 6, knees, and then hands to floor without bending their knees. And it should be palms all the way to the floor. The caveat of this testing, well, there's 2 caveats. One being that your mobility is going to change day to day if you have this, like especially being a female with the ebbs and flows of our cycle, right? Like some days you're gonna be a little bit stiffer, and then other parts of your cycle, you're gonna be like, yep, for sure I can do that. A lot of what I see for patients that have true hypermobility, when they go to do hands to floor, I would say probably almost 50% can't, and it's because of nerve tension. Like they're not truly tight. Their body is trying to protect them. And is it just nerve tension? No, it's probably vascular tension. It's everything that has tension in the system. Anything that runs off of pressure and tension in a body that has connective tissue disorders is not going to operate normally, right? So if you have somebody that is meeting Baton criteria, or they're almost meeting it, we can go look at the actual full diagnostic criteria that I know you cannot read all of. It's like super small. So you'd pull that up, and there's a couple other criteria they can meet over here under the Baton if they're like 1 number off, and then a bunch of other criteria. So you're looking at, do they have velvety soft skin? Do they have skin extensibility where like it's super stretchy? So like if you grab your neck and pull on it, does the skin really come out, or does it like stick a little bit, right? And I have plenty of people that I will say, is your skin really stretchy? And they're like, no. And then I'm like, well, do that. And then it's like, and I'm like, okay. They're like, that's not, and most of it is literally, that's not normal, because so many people, it's hereditary. It's in their family. So their family's like, yeah, that's what I can do too. And they grew up around other people that also have the same thing. So they're like, that's normal. What do you mean? Everybody in my family is double jointed. Everybody in my family has weird stretch marks. Everybody in my family, it takes that long for a wound to heal, right? So other things on there will be delayed wound healing. They'll have atrophic scarring, dental crowding, high narrow palates, pelvic floor dysfunction, all of those things. So you can go through that with, if you feel comfortable. I do have a lot of success if patients are trying to get a diagnosis, filling this out with them and then giving them the paper form to take to their primary care. Some providers are gonna accept that, some are not. As a PT, I obviously can't give somebody a diagnosis, but I can give them all the tools to lead them to the person to hopefully get it, right? If we can give the summary of all of our findings to a provider, and this that says, okay, literally they're meeting all of the criteria, that's super helpful. And the criteria is honestly gonna change in 2026. Ehlers-Danlos Society is really planning to update all of it, since, as you've noticed on the Baton scale, it doesn't look at shoulders, it doesn't look at neck. There are so many people that get missed, and it's super detrimental to their brain space about all of it, because they're like, well, I'm suffering and I kind of have these things, but I don't meet the criteria. And they're like, if I could just, so many patients come in just trying to prove to me that they have these issues, right? Because they've been so dismissed by healthcare repeatedly. Okay, so let's see. Postural Orthostatic Tachycardia Syndrome, or POTS, is a dysautonomia, right? The overheading of that is dysautonomia. So the word dysautonomia means dysfunction of the autonomic nervous system. So yes, so if you are unfamiliar, autonomic nervous system is the thing that controls all of your automatic things. So think blood pressure, heart rate, respiratory rate, blood sugar. Going further off of that, think of like your reflexes even, pupillary dilation. All of those things are going to be impacted. So I tell patients every time that we're talking about POTS, I think it's labeled wrong. I mean, calling it postural orthostatic tachycardia is just labeling one of the symptoms of it, and it makes most people, when they hear it and you say, oh yeah, my heart races when I stand up, they're like, oh, you have a cardiac problem. And sure, a lot of it presents as your heart racing, and it can feel like a heart problem, but it's a whole systemic issue, right? Like just like EDS is systemic through your whole body, multiple system-wide, POTS is the same thing. And so when we shrink it into calling it tachycardia, I think especially for lay people to hear that, it makes it really hard for people to understand the limitations, like I said, how they have such poor quality of life. Like it is not just when I stand up my heart races, there's so many other symptoms that go with it. There's dizziness, there's fainting for some people, which we'll get to, there's venous pooling, pain, there's brain fog, so many other things that go along with it, right? So dysautonomia is going to be more of that blood system dysfunction. So the real underlying problem being we're not getting blood to our head. So a normal human stands up, and within a millisecond, everything corrects, right? To evenly distribute all of your blood flow so that you're still getting the same amount of blood to your head as if you were laying down. When we stand up, that doesn't happen. Vasoconstriction isn't exactly the same, especially when there's underlying EDS, right? So they have this weird connective tissue thing going on in their blood vessels. Nervous system-wise, it's not doing what it's supposed to do, so then they get this drop in flow to their head. I actually have a really cool device that measures the blood flow to my head, so I literally can see how bad or not bad it is and how it relates to my heart rate. So the heart rate part is literally your heart trying to compensate for the reduction in blood flow to your head. So patients don't always come in and say, my heart's racing. As a person that has this, I didn't know that I had tachycardia until I got an Apple Watch. I literally went years with so many issues of dysautonomia before I even was like, oh my gosh, my heart rate's really high. And then I went to a cardiologist, right? That's the first step. Most patients end up at cardiology, and that's totally fine. Cardiologists are great in helping getting a medication on board to manage the cardiac symptoms, but really we need multiple providers for all of the different systems to actually manage the patient better. So getting back into our slide so I don't get too far off. Population is 5-to-1 female. It's just how it is. I think a lot of it is just that the female nervous system is a little bit more fragile. So when an insult happens, our system just turns that dimmer switch way up. And so this is a syndrome of near syncope. So most people think that there's going to be fainting. Only about a third of patients actually faint. We feel faint. We feel terrible. We feel exhausted. We feel brain fog. But do we ever actually pass out? Only about a third of people. So that's kind of a misnomer about it. And it's really that tachycardia with being upright without hypotension. Orthostatic hypotension is not POTS, but it is a dysautonomia. There's multiple different types of dysautonomia. We're just talking about this specific one. Arguably, I would say most patients that have EDS have hypotension in standing. So most patients, when you talk to them, if they're hypermobile and you say, when you stand up, do you get stars or do you black out? And they're like, yeah, doesn't everybody? And then usually something happens and this kicks on and then it gets even worse. So the diagnostic criteria specifically for POTS is going to be a raise in heart rate that is about 30 beats per minute, 30 being the cutoff, when you go from supine to standing. If it's a child, it has to be 40 BPMs. And some people don't meet the criteria, right? Sometimes things are different day to day. If you're more hydrated, if your stress level was down, is it the morning, is it the afternoon? So sometimes when you do this test one time, it looks fine. And then you do it again and it'll be different. So if you do the screening in your office, know that if it's kind of close, it's worth retesting again. Now, diagnostic delay for this is not quite as severe as EDS is, and I think it should keep getting less because of the bigger awareness, especially post-COVID. Long COVID has kind of done wonders for the POTS world. A lot of us with POTS pre-COVID that got COVID got worse, and there's even some research on people that just got the actual vaccination actually getting worse or getting POTS post-vaccination. There's actually studies that have validated that. So the three types of POTS specifically is hypovolemic, which is going to be low blood volume, which is already a precursor with EDS. We know that patients that have Ehlers-Danlos Syndrome have an eighth less blood volume than the rest of the population. So they are already hypovolemic. And then neuropathic is going to be more that autonomic small fiber dysfunction. And then hyperadrenergic is when they're going to have more of like an adrenal component to it, where adrenaline is really driving hypertension and tachycardia in standing. And so those patients, when they stand up on supine to stand, will have a hypertensive and a tachycardia, versus if they're more in the other two, which most people are a combination of all three, it will be more just stable blood pressure and just tachycardia if it's more the first two. And most of the time, people can relate this to a precipitating factor. Not always. Sometimes people are like, I don't know when this started. But I would say the majority of people are like, oh yeah, I had mono, I had COVID, I had a concussion, I had a physical trauma, an emotional trauma, pregnancy, puberty, all that stuff. Okay, this is a review of your sympathetic and parasympathetic, just in case anybody wanted to remember it. I know it's probably really small up there, so not super helpful, but it is just a gross reminder of all of the things that your autonomic system controls. Okay. Moving on to Mast Cell Activation Syndrome. This is our last big acronym. So MCAS or MCAD, we'll call it. And it is a syndrome where mast cells are excessively responding to things that they sometimes don't need to respond to. So this is not a true allergy. This is a dysfunction in mast cells themselves. And mast cells have tons of receptors on them. They have cortisol receptors, so stress can trigger mast cells. They have so many receptors, and they're in all of our different systems. So different symptoms can come up from skin, like hives and rashes, flushing, that type of stuff. They can have GI, where they're going to oscillate between constipation and diarrhea, cardiovascular symptoms, we know POTS, or variability in blood pressure, neurologic symptoms, respiratory symptoms, the list goes on. And they can be mild to severe depending. So some people can go into full anaphylaxis from an MCAS response. Again, female bias, again, diagnostic delay. And the diagnosis for MCAS isn't great. Labs can support it. They're not always going to super coincide with it. It's really looking at how the patient's responding to things. And a lot of it is removing triggers, using histamine blockers, and a lot of trial and error with most of the medications for all of this. So if you have somebody that is super sensitive to all the things, smells bother them, tape bothers them, lotions bother them, I would be suspicious. And mast cell really is something that kind of brings in a lot of how much fluctuation can happen with Trifecta. Yes, there's the huge hormone piece for females, but also in different parts of our cycle, histamine is also higher. There's different parts of the day where your histamine is higher. So when we really tease out how much these symptoms can really be, well, today was a okay day, tomorrow might not be. And so much of these being invisible illnesses and very variable illnesses make also getting diagnoses really hard. And then also just the stigma around them can be really difficult, because you can see somebody out and about exercising, and then the next day they're in a wheelchair. Like, there are very big swings that we can have. So this is one of my favorite little charts, because this shows you the true triad trifecta. And it's great to just see all the different overlap. And I think you can tell there isn't really a spot that doesn't have something in it, right? So, and I can always send this actual thing out so you guys can have it. But so MCAS is really going to have all of that, like flushing, nasal congestion, wheezing, throat swelling. EDS is going to be more that skin hyperextensibility, tissue fragility, easy bruising. POTS is going to be more the lightheadedness and visual blurring, vertigo type symptoms. And then when we really look in the middle, that's all three: weakness, fatigue, abdominal pain, nausea, vomiting, diarrhea, hypotension, exercise intolerance. And so some of these can be really broad symptoms when people come in and they're just like, I just don't feel good. I feel terrible. Like, I don't feel like myself. Like, maybe they had COVID and they're like, I just can't get back to it. And if you don't ask some of the other questions, like, what's your GI like? Are you dizzy? Are you fatigued? what else is going on? Because sometimes people just notice small parts. They're like, I can't do the things that I used to do. And if we dig a little bit deeper, they might notice more. And most of the time, people are so disassociated from their body when they've had these diagnoses for so long and no one's been able to give them an answer. Their body isn't safe anymore. So it's like, okay, if I need to keep going in my life, I'm going to ignore this and move forward. So by the time that they even feel comfortable or safe enough to tell somebody about it, sometimes they don't even know. As a person that has hyperpots, like I had no idea what was going on in my body. And then eventually was like, you gotta be kidding me. Like, what? And then when it all links together, you're like, okay, great, I have something to move forward with. Okay, this is just a really great graphic to show you how different these people are. I tell patients all the time that they are an N of 1. Not a single one of us looks the same. All of our symptoms are going to be different. Some people are going to have really big MCAS symptoms, and maybe dysautonomia is a little in there, and oh yeah, you do kind of meet EDS criteria. Or it's gonna be like, you definitely have EDS. Maybe let's screen the other two, and maybe they have a teeny bit of the other stuff. But usually you're gonna find that pattern where they all overlap, at least to some degree. So, all right, so recognizing these patients and reducing harm to them. Most of you are people that are passionate about caring for people and doing great things, so a lot of this isn't going to be things that I need to be preaching to you, but iatrogenic risk is huge for these patients. Like, by the time they get to me, I spend my whole first visit talking about how much this is a trauma. Like the medical trauma for us as humans in America, first of all, just trying to get healthcare is difficult. And then being a person that's had diagnostic dismissal, triggers from having procedures or just medical treatment in general, and then the care fragmentation of you trying to figure out from provider to provider, and one provider saying one thing and another provider saying something else, and then going years without an answer where you're like, is this in my head? And people have told me it's in my head, so it must be in my head, right? So yes, the normal labs and nothing wrong is one of the most common problems. None of these things show up on basic labs, right? And so we really need to do more of those like objective testing, and most basic providers don't have time to see that or hear that. And most of the people in this room get plenty of time with our patients. So when they start saying things and you can be like, that sounds like I'm suspicious. And so you can really make a huge change just by being aware of like, oh, maybe that's a thing going on. Let's see, was there anything else in here? A big thing to be aware of for EDS in general that I don't think I've touched on yet is that we have paradoxical responses to medications, and I don't think a lot of people know that. So is there anybody in here that knows they have EDS? Okay. So if you have had a patient that you're suspicious of having EDS, and maybe you test them and you find out, an important piece for them to know is if they're gonna have a procedure done, we're either gonna not respond to medication or we might over-respond to medication. And so, especially lidocaine, like a lot of the additives and preservatives in medications or injections can be really MCAS triggering, but also lidocaine specifically, like I have patients that will go have a procedure done and lidocaine does nothing. So they are numb, 0. And then they go get a procedure done and they're like, that's crazy. You can feel that still? And they're like, I've maxed you out on stuff. I've had patients that wake up in surgery and it's all because they don't process things the same. When I get dental work done with lidocaine, I have the opposite response. My face is paralyzed for like 12 hours. So it kind of can go either way, but just giving patients the awareness to go into a provider and say, hey, I have Ehlers-Danlos and I don't know, I've never had this done before. Or if they've had a response and then you tell them, hey, have you ever had a thing that's happened? And they'll be like, oh my God, yeah. And then you're like, it's probably because of this. If you have to go again, then you can say, I have this, I know I respond weird, versus just being like, I don't think my body likes that medication, right? Like it's a lot more validating to have a diagnosis that you can say, this is what's happening to prevent that. Okay. So I have some real patient examples for you. This first patient, she is in her 20s. She had years of unilateral and episodic neurological symptoms, weakness, numbness, seizure-type activity that happened a lot after a long day, sitting in the car driving home. She got an FND diagnosis. She had not been screened for much of anything, unfortunately, and one of my patients is good friends with her and was like, "You sound like me." And I got her into my clinic, and on a Sharps purser, she was immediately positive with immediate relief in her whole left side body symptoms. So significant transverse ligament laxity, so she is an AAI or atlantoaxial instability. And she had been given this technically psychiatric diagnosis for years. And unfortunately, this is not the first time I've had an FND patient that did not have an accurate diagnosis. It is a soapbox that I can get on. My other patient had West Nile meningitis. So that's a diagnosis that I'm always a little skeptical of because it's kind of like fibromyalgia, which we'll get to, where it kind of becomes this like, I'm not sure. Here you go. FND stands for functional neurological disorder. Sorry, I love an acronym. So essentially it is the modern phrasing for conversion disorder. So I know, I agree with the eye roll. So now she's gonna do great because she's in rehab though, so we love that. My next patient, she was a patient I've been seeing for years with Ehlers-Danlos. She's very high functioning. She does aerial silks and hoop. She manages her EDS with all of her strength training and stability work. And she had come in for one of her just like wellness visits, and I mentioned how she was having all these allergy things and was going to her allergist and had been having these anaphylactic reactions to allergy shots. And I was like, okay. And I was like, well, they did like IgE testing. They did serum testing on you. And she was like, no. And I was like, they just did the pinpricks on your back? And she was like, yeah. And I lit up to everything. And I was like, oh gosh, you have MCAS. And she was like, what is that? And then immediately we told her allergist, and they were like, immediately stop. But they didn't test beyond that, right? So like, and she literally just started carrying around EpiPens because she was like, I have such bad allergies. Like, this is so crazy. And so they stopped her shots. Now she's getting treated for MCAS. Things are way better. And then the last one is more that premature labeling. So this patient was 26 and had sudden fevers, chest pain, hypersomnia, going unconscious anytime seated, exercise intolerance, weight gain, all those things. At rheumatology, was told that it was fibromyalgia within about a 5-minute screening. Did not have any autonomic or mast cell evaluation, was offered Celebrex without any diagnostic workup. And this patient is me. So this is also how I become so passionate in this space, as it took me years to get a real diagnosis, and I am a provider. So I was doing all the things that I could, and that moment for me was so groundbreaking because I was like, if I was a lay person, I would have said, okay, I have fibromyalgia, and just taken a medication for the rest of my life and attributed everything to that diagnosis. So words are really important. Dumping somebody into a diagnosis without still looking at the bigger picture, right? All of these could have been prevented with somebody doing a better workup before dropping them into the care that they immediately thought was what was right for them. Okay, so trauma-informed care, something that I'm super passionate about. And so creating safety for these patients is really like the most important thing if you are seeing them in your clinic, if you already know. I mean, I think a lot of us already do this for the people that we have. So really giving consent before doing anything to their body, reducing sensory overload. A lot of these patients are neurodivergent. That is a piece that we know a little bit already. There's a correlation there. And then giving people options, not just telling them what to do. So if you decide, okay, there's X, Y, and Z that I think you need, these are all the people that I want to refer you to, don't jump to that. Say, this is what I think. What would you like to do? What do you think is best? Because they're living in this body that has all this stuff, and they're like, my priorities are X, Y, and Z, and my priorities might be 3 different things, but theirs is something totally different. And then really encouraging them to tell you what has worked and what hasn't, because sometimes they've tried way more than you think they've tried. And then really empowering them to validate their symptoms overall and educating them on self-management and that there is more that they can be doing. I think one of the very big misnomers that I see a lot in all the support groups is that there's nothing we can do for EDS. And POTS, you can just put medication, and MCAS is just histamine blockers. And there's so much lifestyle things that we can change for these patients that will change their whole life. But Big Pharma doesn't make money off of that. And regular big physicians don't have time to sit there and tell them how much compression and diet and hydration and all those things can really change their life. They're just like, oh, they told me to drink more water and salt my food. That was it, right? And unfortunately, that's sometimes all they have time for. So it's not necessarily their fault if that's all they can give them, but there's so much more we can do. And then disability humility, right? So avoiding the all in your head framing. And I spend so much time with my chronic pain patients talking about pain science and how, yes, at some point it is descending and coming from your head, but it's not in your head. It's coming from your head, but it's not in your head. And then really respecting adaptive strategies, like there's going to be people that need mobility aids on some days and not on other days. Sensory needs specifically, I have a lot of people that need to wear noise blocking headphones. Support stuffed animals is a thing that I've seen across all of my neuro rehab in general. And so really just like supporting people in those things is super important. Why words matter. So language really is a clinical intervention. I think that it's definitely undervalued for providers. I feel like pain science and going off of the things that you say to people is one of the biggest pieces that you can do. It can harm more than you ever know, and shifting what you're saying can go a really long way. So really it will shape people's pain and fear, their autonomic arousal for sure, and then their trust in their body that they really don't already have. Catastrophic and harmful phrasing, right? So like saying things are damaged, your disc is blown, like things are unstable. So many patients think that they're fully dislocating joints when they're really only subluxing joints, right? There are plenty of EDS patients that are fully dislocating. But the narrative that they have a fragile body that is just going to dislocate and slide and slip all over the place is unnecessary, because most of the time that's not what's happening. Yes, they have some extensive mobility in places, but they're not going to fall apart if they try to do an exercise if you give them the right movement and the right stability. But so many patients are so terrified of the instability in their body that they're like, I need a neck brace. I need this other thing to hold me up. And then they start relying on the bracing, which bracing has a place for sure, but then they start relying on it because they're like, if I don't use this, my whole body, I'm just going to melt to the floor, right? So that's super important. And then obviously trying to use hope-based neutral wording as much as you can. And really, so many of these patients are already so fearful. And so the threat perception that they already have is so high, which is going to increase central sensitization, which increases pain and increases autonomic arousal. It makes everything so much harder for them to climb out of that hole. So using that accurate, neutral, non-catastrophic wording is really important, and I do have some examples of what that might look like. And mechanical clarity, like that's one of the biggest things that when I've asked patients, like, what do you want people to know and what do you want them to be able to say to you? It's really like not, it's just going to happen because you have EDS, or it's just going to happen because you have X diagnosis. Like, this is what's happening in your body, this is why, and these are the things we can use to manage it. And even if you don't know the thing to manage it, like, this is why it's happening. And just giving them that, right? Like, they want to know the physiology. They want to know the anatomy. If they're just thinking of what they see externally, they have no idea. And then they're going to go ask Reddit. So give them more. And then I really liked this phrasing one of my patients gave, that words like damaging create more fear and distrust in our bodies. Because like I said, we already don't trust our bodies, and then when a provider is saying those things, it makes it even harder. So I'm not gonna go through all of these. Like I said, I will send this out to each of you, but a couple of them that are good, right? So, and I think it's not cutting off the top on yours, okay. So like when they're describing multiple systems, you can say instead of that's a lot of symptoms, we can say these conditions commonly involve multiple systems, so your experience makes sense physiologically. Or one that is really important is when you don't know the answer, instead of saying, I've never heard of that, I don't think it's related, it's not something I see every day, is a great phrase. And it's absolutely worth looking into, and we can explore it together. Like, if I could say a phrase that this whole population loves in general is just like, I don't know, but let's find out, right? There's nothing more damaging than telling somebody something when you don't know the answer, because you feel like they're not gonna trust you when you say, I don't know. Like, anybody in this room will say, if you went to a provider and they were not sure, and they said, I'm not sure, let's figure it out, or I'll look into it, that instills way more trust than giving them some half-hearted answer that you're like, I don't know, that sounds weird, I don't think that could be it. So again, words, super powerful. Okay, so clinical management, we're not gonna go into a lot of treatment for these patients just because that could be a 9-week course that I hope to make it someday. But really educating and validating patients on what they're experiencing could be the number one thing that you do, right? Like that can be enough to change their whole trajectory. Self-management tools are our number one thing for them to start doing, and a thorough assessment to rule in and rule out is also really important, and that might mean referring. And unfortunately, there's not a ton of great providers that specialize in this, but there are a lot of lists of people that are at least a little bit more aware, and I'm hoping to make a better group of people up here in the Valley. There are some down in Tucson. There's more of an actual provider group there. I'm working on trying to build one up here, but there are some people. So if you guys have any patients that need a referral, you can always reach out to me and I can give them the names that I have of who would be a good option. It can be hit or miss though. And then ongoing assessments, because literally this changes so frequently. Like this is a chronic thing, so month to month, year to year, it's gonna change over time. My symptoms look very different than they did 9 years ago. So if somebody looked like one thing and they've been treating it the same way for quite a few years, they need to be reassessed because their whole system's gonna change, especially if we have any transition between like puberty to like adulthood or like pregnancies or menopause. Like all of that is going to drastically change things. And then a place for us to start, if any of these are within your scope. POTS mostly is going to be pacing as the first thing to give somebody. Really looking at, if you guys have heard of spoon theory, where you wake up with a certain amount of spoons, something has an amount of spoons that it costs to perform, like doing the laundry or going to the store or just getting out of bed. And if you woke up with 4 spoons and all the things you need to do throughout the day take up 12 spoons, you have to pick where you're spending your spoons. Big 5 is one of the things that we talk about a lot in POTS. Sodium is super important. Fluids are super important. It's a lot more sodium than you would think. We recommend up to 10,000 milligrams a day for these patients. Compression can be super helpful. Sensory-wise can bother people though. Nutrition. I will say it forever. I have a certification in chronic pain nutrition, and most of my stuff has gotten amazingly better treating it functional med-wise through dietary stuff. So I will die on that hill. And then reconditioning, I have in bold to be very specific that this is not progressive exercise. If you go on the internet and you look up protocols for POTS, that's not what you're doing. There are protocols. They do not follow it as a protocol. So like it is an N of 1. We are specifically tailoring it to that person. I think I actually said my phrasing on the bottom one here. So instead of saying you need to exercise more, I have your nervous system needs very slow paced physiologic conditioning, not traditional exercises. So we'll start low and slow, build safety in your body with sustained movement, and then adapt each step with how your unique needs come up. So when I teach patients, their rehab, they're going to be doing cardio and strength, but they're really retraining their nervous system. That's literally the lens that I tell everybody, is that it says it on there that it's that, but just know that like none of this is for relatively that, especially when we're first starting out. We're just teaching your body that it's not running from a bear when you're doing sustained movement. Like, we are focusing on what your internal environment is while you're moving. We're not just trying to get you doing exercise. Like, it's not exercise for your body, it's exercise for your nervous system. For EDS and hypermobile spectrum disorder, joint integrity, stability training, especially closed kinetic chain, proprioception and balance. Proprioception is impaired for anybody that has hypermobile. So really focusing on that can be really important. Super light is the caveat, I will say. And then MCAS is really going to be tracking triggers, removing triggers, working on nutrition, and using histamine blockers. What not to do. I know I said in my important word things to phrase things nicely, and I'm going to be really negative on this slide. But these are important things. So don't ignore patients' limits. They will be apprehensive with things. Listen to their apprehension. And then don't assume standard protocols. Don't change things more than one thing at a time. Like, so sensitive. Like, if you increase something, we're only increasing that. If you decrease something, we're only decreasing that. Don't forget about paradoxical responses to medications and procedures. Please no aggressive therapy, manual strengthening, or exercise. These patients are sensitive. And then avoid unnecessary procedures, imaging, and negative language. One thing that I will add through all of this for EDS specifically that I did not put on here is being very careful with necks. As somebody that treats upper cervical instability and has upper cervical instability, you can mess with somebody really bad doing what you perceive as gentle. With the brawl stuff, which I do tons of neural to head and neck, and people do wonderful with. But if we go into some deeper stuff, even just positioning wise, like, these people do terrible at the dentist. Like, there are things just like when they're put in it, like, I have a patient with upper cervical that is so flared after she had an MRI, just from like the pillow they put her on. So like, being very careful with positioning, being very careful with manual and exercise. They are sensitive, and then this hill forever will always be no manipulation, like a thrust manipulation to the neck for anyone with hypermobility. Please don't do it. Even if they don't know they have upper cervical instability, like, it's not worth the risk, especially if they don't know if they have vascular EDS. So that is a very important one. So other not to do's for POTS: avoid rapid or multiple position changes. Oop, go back. And then extended periods of standing, like especially if they have to stand to talk to you or the front desk to schedule. Please don't forget about that. That is a very triggering thing. And then we're not relying on heart rate. We're using rate of perceived exertion, or RPE. For EDS, I will say no stretching. That is how I wanted to leave it, with the caveat that it's mostly no end of range sustained holds, right? Like, dynamic mobility is fine. Like we said before, the things that you're stretching are likely not their muscles. It's their nervous system and their blood vessels and fascia. And I think a lot of people in here either do myofascial work or do Barral work and know that if you put tension on that, it's not going to be happy with you. Even though a lot of us love the sensory of a stretch, right? Like, but it is not truly stretching. So it'll backfire for you in trying to help these patients. Avoiding high impact, heavy resistance, and then mast cell, knowing the triggers for your office. So avoiding temperature extremes, scents, friction, lotions, adhesives, and then really checking with their known tolerances before you add or change things, medication, anesthetics, that type of stuff. Okay, referral and coordination framework that patients can actually use. So validated organizations are great. So the Ehlers-Danlos Society, Dysautonomia International, TMS is for the MCAS peeps. This will be at the end for their websites as well, but those are great resources. Those websites have tons of stuff for providers, tons of stuff for patients, and it has everything that they could need to know. So if you do nothing else other than being like, I'm suspicious that you have this thing, here's this website, look into it. That's definitely a great option. encouraging patients to guide specialists when they don't have an option. They can go in the support groups and see if somebody else has a great one, or all of those websites actually have provider directories. So, and I know Dysautonomia International is pretty specific in letting people in. Ehlers-Danlos Society, I think if you submit, you go on, and then I'm not sure about the MCAS network. And then really helping to communicate across disciplines. So if you do refer somebody and you're suspicious because of X, Y, and Z, if you can send just like a quick snippet of like, these are the things I think and I'm noticing and I'm suspicious of this, and just send that with them so that they don't walk in and they're like, I don't know. My person told me to come here and they think that I have a thing. Like if you can just have like that little tiny, it can help so much to reduce 1, misdiagnosis, and 2, dismissal. So validating symptoms for sure, knowing when to refer, especially for red flags, because a lot of these issues, especially dysautonomia, are mimickers. So patients can have other things driving their dysautonomia that's not just POTS. And so we need to rule out the other stuff if we can, as quickly as we can. So there's other things that can be a piece of it that's driving it, not just MCAS, like toxicities or vitamin deficiencies, mineral deficiencies. That happens frequently. And then empowering patients with language. And all right, so what can you guys do tomorrow within your scope, obviously? Validating symptoms, obviously, I think I've honed that one in for you guys. Screening for orthostatics, if you can, if you have the time for it. The true test for like in office for POTS specifically is called the 10-minute stand test. So if you have 10 minutes, you can look it up online. It's literally a supine blood pressure and heart rate, a seated or a standing blood pressure and heart rate immediately, and then you do intervals of 2 minutes, and see what it is, and then you get a 2-minute rest at the end and recheck, and you're seeing, does it go up? I had a gal the other day that I literally tested, and it wasn't until minute 4 that things really changed for her. So it's worth it instead of doing just the quick supine to stand if you have the time for it, but also knowing that it can make people feel really crappy after. She wasn't very happy with me after standing for 10 minutes like that because they want to move, right? So one of the big things that we'll do is to basically have counter maneuvers that a lot of us will do without knowing that we're doing it by either like moving your legs, curling a leg up. Like if somebody comes in and they're like all scrunched up in their chair when they first come in, I'm already suspicious. If they're like full cross leg all the way around at their ankle, I'm suspicious. And then screening for hypermobility, especially if you've seen those things, or if you're seeing younger patients and you're like, these injuries don't match up, right? Like why are you 7 and you've already had so many ankle sprains and a bunch of other injuries, right? And then asking about heat intolerance, GI issues, rashes, sensitivities, menstrual cycle patterns that are probably not PMS, that are likely more related to something else. And avoiding premature reassurance. So when you hear things, ask more questions. Don't just say, oh, that's weird, that's just a thing, right? Like really dig if you have the time to, and then refer them when you can, and then again, giving that summary if you can to that provider. So my summary of everything that we talked about, I know this was a lot of things and this has a lot of words, but really recognizing patterns early, and then validating physiology, not pathologizing patients. So, and then reducing that iatrogenic harm, and referring really intentionally, and partnering with the patient, letting them be part of the choices in the plan that you're making. And then these are the resources for clinicians and patients. Each one of those will have, like I said, a bunch of good stuff. These are my references. And then if you guys have any questions, this is my QR code for my business card. So if you would like that. But yeah, go ahead.
What docs would you like to evaluate? The big one I know is Saperstein, but one, he's super expensive, incredibly difficult to get into, and so which docs do you
Yes.
send us of like, here are the docs that are doing a good job at diagnosing?
Yeah. So Saperstein also, I think, is also on hiatus from treating. I know he has cancer, but his NPs, I think, are still there. But yes, he is cash pay, so super expensive. So Dr. Goodman is the most ideal person to get in with. I know he has a wait list now. He used to run the autonomic lab at Mayo, and now he's at Honor Health. So he takes insurance, so if people can wait to get in there. There's also Dr. Levine is that same office. Those are both great options for that. There's a
Location is that at
Honor Health. It's like Scottsdale.
Scottsdale?
Yeah, I forget what the actual cross streets are. It's like a separate building. Yeah, but that's definitely the best bet because they're going to be able to screen for all of the dysautonomias and make sure that we're not missing anything. They have their own autonomic lab, so they won't. Yeah, so I know Goodman is an autonomic neurologist. I'm not sure if Levine is. I think he is, though. But yeah, they have an autonomics lab. So, because sometimes people will go get a tilt test. Tilt is kind of that like standard that they typically use for POTS. When they do it at Mayo, a lot of the times, especially if a cardiologist has sent for it, it will just be a cardiology tilt. They won't actually test all of autonomics. So they'll do a QSART where they're looking at like their sweat. They'll also do like an HRV thing with a Valsalva when they do it in an autonomics lab. So yeah, that's definitely a good one. And then I know Arizona Allergy. So I know somebody wasn't having a great experience in like Mesa Gilbert, but I know that I think it's the Scottsdale one is pretty good for MCAS. But I definitely have a list, so if you need somebody, you can always text me. I think there was another question.
Yes, I was curious about the food recommendations.
Yeah.
Gluten-free or dairy?
Yeah. So food can be a tricky one because there's definitely people that have histories of disordered eating in this space too. So I don't always jump immediately to fully like cutting things out, right? Like with the gastroparesis, that is a huge piece for these patients where literally like GI motility is shut down. We're nauseous. Like I have people that are not eating at all. So the first thing we're starting with is just like, how do we get protein and nutrition into their body? Some people go on to feeding tubes with this diagnosis. So I try to shift people to getting more protein and getting some cleaner options, at least at first. If they're further down the line, yeah, like there is research that this is autoimmune. So it is an autoinflammatory autoimmune disorder is what we're starting to lean towards. Go ahead.
All three, or are you saying EDS specifically?
Dysautonomia, or POTS specifically. Yes. So yes, thank you for clarifying. So like EDS is genetic. You're going to always have it. I would say the management of chronic pain with EDS with dietary changes is huge, especially with getting hormones in balance. But dysautonomia, yes, like I ideally try to get people closer to an autoimmune protocol as much as I can. That's what changed things for me. I was, I think, 4 years into going fully unconscious. Anytime I sat down, I couldn't drive. I did an autoimmune protocol, and it went away in the first month. So I, the poster child for trying to make anti-inflammatory shifts with food, just because like we're so sensitive to additives and even just like supplements, right? So like there's more we can do with taking things away than adding things in sometimes. So definitely for that. And then mast cell for sure too. Like if they're already trying to find the foods they can eat that don't trigger them. Like I have patients that come in sometimes that are only eating like 6 foods. They're like, that's it. That's all I can have. And so diet with this population definitely can be difficult because you're trying to manage so many different pieces. But yeah, I think as much as we can shift to that. And I have patients that will do 30 days of a trial of no gluten, no dairy, no sugar, or Whole30 or an autoimmune protocol. And then they realize it's a lot better, right? My patient that just had the allergy shots, she did an AIP protocol for 30 days and huge changes. So it definitely is like a place to really feel out who the patient is and if it's okay to really give them anything that feels restrictive. So that's my caveat I would say about that. But if somebody's like, yeah, I'm willing to try stuff, I feel like most humans should go on some sort of like 30 reset to kind of get inflammation down. So any other questions? Yeah.
So I just read an article recently that was relating autism to EDS.
Okay.
Have you heard anything about
Yeah, so it's not like a causation thing, but there's definitely a correlation between EDS and neurodivergency. So most of us will have some form of like either autism is a common one, ADHD is super common. A lot of people don't have like known diagnoses of that, but I might mention it and then they're like, maybe. So it definitely adds into the sensory component of it, and I think it sets up patients with Ehlers-Danlos, if they do have neurodivergency, to end up with dysautonomia because their system is so sensitive. So, yeah. Any other ones? Cool. Yeah.
With your Trifecta group,
Mm-hmm.
how much are you touching the other ones that are coming with it now, which is your
Constantly.
mouth, so your,
Yes.
your
Mm-hmm.
nutcracker syndrome, your vascular
Yes.
syndrome,
Yeah, so like,
I'm starting to see
Mhm.
people, especially post-COVID,
yes.
and that gets super hard to figure out what's the driver.
For sure. Like this is super complex, and I think that's why a lot of providers don't want to dive into it, because once you like open that box, there's so much, right? When we look at vascular compression, upper cervical instability, any of the other like multiple autoimmune things that can be happening. So yeah, like I always have a hierarchy of things in my head when I'm suspicious of this, and then when I have somebody that has that, like I have my eyes out for Chiari malformation. Like there's so many other diagnoses that could be in there that haven't been picked up on yet because so much of it overlaps, right? Like I constantly have patients where I'm like, I'm always monitoring their legs because I'm like, okay, do we have venous compression? Is it really just venous pooling? Like, do I need to be more suspicious in your abdomen? I do have a patient with MALS right now that is doing great with the Baral work instead of anything else that they wanted to do for her, so that's lovely. But she also has multiple venous compressions and arterial compressions. She has bilateral thoracic outlet. And so, yeah, it's definitely a lot, and it's the whole body. And so I think some of us are great providers for that because we are whole body providers, so we can really be picking out those things. But yeah, like there's so many other coinciding and co-occurring things that can be going on that we need to have our eyes open for.
Like small fiber neuropathy, where does that fall into your question too?
Yeah.
Because
Mm-hmm.
you have it,
Yeah.
tag along friend, or what do you think?
Yeah, so there are things that we know about like the small fiber autonomic nerves that drives neuropathic POTS. And so they're definitely looking more at that, right? The Dysautonomia International's conference that I went to, there was a big debate between a couple of rheumatologists because they were looking at all of these like different markers, right? So when we see rheumatoid disease, it has specific interleukins that are elevated. The study that they did, they looked at POTS and everything was elevated. And all of the rheumatologists in the room were like, okay, so what do we do? Like even the anti-inflammatory stuff is up, but the bad stuff is up. So like, what do we do with that? And so they just don't have enough information yet. And actually somebody had asked the guy that did the study, he was like, so if we know the small fibers have an issue, because he was like, where do you think the autoimmune or inflammation is? And he was like, I think it's in the nerves or the blood vessels. And he was like, so when you do a biopsy, is there inflammation in the nerve? And he's like, we don't know yet. So there's just a lot of research that we don't have, and I think soon we're probably going to have way more in the next 10 years, especially post-COVID. So thankfully not thankfully, let me take that word away, but a lot of providers, especially doctors, got COVID and have long COVID. So they're pushing more for research now. So there's a lot of studies coming out that are on long COVID, but a lot of long COVID has dysautonomia. So in that space, we're definitely getting more research. There's definitely a lot through the Ehlers-Danlos Society that's coming up for 2026, which is great. So that should start changing. And then MCAS hopefully will start getting some more stuff in there too. But yeah, there's not a ton of research. Hopefully we'll just keep getting more. But I think just in general, like people starting to be aware of it and being able to talk about it and reduce stigma is so big. Yeah, go ahead.
I just want to say this was so eye-opening and really an excellent presentation.
Great, thank you so much.
I really feel like you are single-handedly changing how people will be receiving treatment because
Love that.
you're a wonderful messenger.
Thank you.
And maybe you can change protocol over time.
We're trying, man.
I wanted to just ask you out of curiosity, I mean, that is actually almost like debilitating, where they're actually not even getting out of bed anymore and can't really live.
Yes.
That coincides oftentimes with light sensitivity. And I have this one particular woman where we had, by the way, really amazing success. It all got kick-started with her having a mold infection. Then it ended up, spiraling into this complex chronic fatigue syndrome.
Yes.
And she was actually in her early 30s and 4 years on disability, not being able to actually live a life.
Yeah.
And more and more of those cases are popping up, and like you said, they're very interconnected.
Correct.
So have you seen a link there between sort of like an autoimmune situation like mold, and then all of a sudden this whole spiral?
So two things. So myalgic encephalitis or chronic fatigue syndrome is one of the differentials here. So that's why with POTS and dysautonomia, like we can have both, and that's why exercise can be so sensitive. They have changed the recommendations for chronic fatigue that like exercise is an actual no. Like we do not do it. For POTS specifically, I always say like your exercise is not to the detriment of your ADLs. Like you should be able to do your activities of daily living. If you can't get your life done, we're not pushing that, right? Like that's a huge piece. But yes, so we're always looking for ME when we have these patients because it can overlap. So that's definitely there. And we know the device that I wear in my ear, they've done studies, preliminary studies, and one of the first things they were looking at was actually chronic fatigue syndrome. And they saw, I can't remember how long they were on the bike, but they did like a short bout on a recumbent bike with somebody that had chronic fatigue syndrome. And the blood flow reduction to their head lasted for like 2 or 3 days after like a few minutes on the bike. And so you can imagine if it's a similar mechanism, right? So I think we don't know enough yet. But yes, it is a reduction in blood flow to the head. And so then your brain can't operate well because it's getting extended periods without blood. And so, yes, that's definitely a huge piece. And then the mold part, for sure. I am a person that I had a mold re-exposure that I think was a huge piece of my retriggering. I test patients for mold, and I do see it in quite a few. So if I'm getting some of those things that I'm thinking, I'll send for testing for it. And then as another example, because I'm a great example for these things, if you've seen mold ends up driving sometimes heavy metal toxicity. And so I ended up having tons of extremity weakness, coordination dysfunction, all that type of stuff. We thought I had MS. It turned out I had mercury toxicity. So there's things like that that are overlaying that I think a lot of it just becomes like your system is so beat down. Like if you aren't processing things and your blood isn't working the way that it needs to, you're not moving your body, your lymph can't move, right? Especially when dysautonomia impacts your sweating, right? Like people are either abnormally hyper sweating or they're not sweating at all. And then they're gonna have toxicities that are gonna be huge in driving symptoms. So yes, go ahead.
What is this device?
So this is Lumia. So it's this little tiny guy in my ear. It has a little sensor on the back. It goes off of the blood vessels in your ear to look at your internal carotid. And so it measures flow change from that little device. And it looks at heart rate. And this is Lumia 1. They're actually releasing Lumia 2. I think they just sent the email, 2 days ago, that Lumia 2 is coming out in, I think, January or February when people can start ordering it. Lumia, Lumia.
Can you order it without a prescription?
Yes. So it's not a medical device right now.
How do you use the information?
Yeah. So it's mostly just for management. Like I think at some point the company has said that they would like it to become an alert, so that especially if somebody is a fainter, they'll get an alert to their phone before they pass out. I would love for it to alert me when my flow's down, because sometimes I'm totally aware of it, and other times I'm like, I have no idea. So basically it gives you a little graph. My phone's over there recording. It gives you a graph and it shows you where your flow is, like on a percentage of 0 to 100, and then it gives you where your heart rate is. And so you can do live modes where it literally will check consistently. So a lot of it is like testing things. So like you can put on compression and then say, okay, when I'm wearing this compression, does my flow actually improve? And then you can kind of have an objective way to be like, okay, it's worth me doing that. Or looking at different types of exercise to see, okay, when I'm doing this, or like how much does a Valsalva change my symptoms? How much does eating a certain food change my symptoms, right? So many of us have significant blood glucose dysfunction, especially like postprandial hypotension. And a lot is because of blood shunting to the stomach, and so it goes away from our head. And so like there's certain things like sugar and carbs, like those are the big things to reduce at least. And then like bigger meals, reducing those. And so like it can be really helpful in that way to check it and then be like, okay, what does that look like? Sometimes I don't check it till the end of the day, and then I'm like, oh, what was I doing at that time? Other times it's just like validating for patients to be able to be like, oh yeah, that's why I feel terrible today. My flow is all the way down. Or you'll see like a steep change sometimes, and you're like, okay, what caused that, and how do I mitigate it? So it's definitely a tool. It's not something that's going to fix anything, but I hope in the future that it's going to have an alert system. I know the guy that created it, his dad has orthostatic hypotension, and he faints and gets hurt. And so he really wanted to make it for him so that it could be something to give him an alert before that. I know Lumia 2 is going to track temperature, so it'll be like a cycle tracker as well. And then I know it's going to track sleep. So it's kind of going to be like an Oura ring, but also tracking blood flow to your head. So. So they're actually changing it, so it won't be this. It's actually going to be a little piece that can either be like a lower hoop that kind of looks like an ear huggy, or it's going to actually go in the back of an earring. So it'll be literally an earring back instead. So you could just do the hook. It's like a little huggy. That.
I'm just thinking so elderly too. I have a guy right now who has a bionic.
For sure.
Interesting things, but I'm starting to think pressure or blood flow.
Correct. Yeah.
Mm-hmm.
Mm-hmm. Yeah, I mean, do an orthostatic test. It's definitely helpful. Like, I mean, now that I have mine, I can like put it in people's ears when I have it on the hook one versus like this is like customized to my ear shape. So it's nice to have as a thing in the clinic to use as well. Also knowing that like diabetes leads to dysautonomia eventually because of small fiber neuropathy, right? So like we know at some point in diabetes they're going to have some degree of dysautonomia, and so even just educating them that the things they're experiencing are that. Go ahead.
So I think you've been wearing this like 3 years now, or is it?
At least a whole year, maybe 2.
I feel like I remember
When I first was like found out about it, it took like a year, almost a year for me to get it. It took forever. I was super excited.
Since you've had it on,
Mm-hmm.
have you had it on and had COVID? And have you had any blood flow changes to your head or symptoms?
I don't think I've had COVID since I got it. Yeah, so I wouldn't really notice that. But like, it is really good feedback in that way to be like, okay, what's changing, what's not. Like, for me right now, I think I'm actually shifting out of hyperadrenergic and a little bit more into the other two. And so I've had way worse blood flow to my head because I'm not getting hypertensive. And so like I turn mine on a live mode when I go to yoga, and like the last couple weeks when I've turned it on, I black out the whole class. And I'm like, okay, well if I keep my eyes closed, I don't know what's blacking out, right? Terrible, don't do that. But then I end up stopping because I'm like, okay, and then I have the validation to look at it and say, okay, when I'm blacking out, is it actually just like visual changes, or is it really a true drop in blood flow, so that I can actually say, okay, am I harming, or is my body just more sensitive? So it's good for feedback in that for sure. Yeah.
Just because I happened to see a webinar on this morning,
Yeah.
and you seem so knowledgeable, I'm just going to ask.
Go.
So this morning I watched a webinar about a low-dose microcurrent, and
Okay.
using that to take down inflammation, using that to eliminate pain, and using that to, they were talking about how we're electrical before we're anything else.
Yeah.
And the microcurrent works to kind of reestablish electrical communication between organs and blood flow and all the different parts.
Yeah.
Are you familiar with microcurrent at all, and do you have any thoughts about it?
I don't personally use microcurrent. I don't know enough about it, but I do know that we have electrical dysfunction for sure. That's why so much of us need so many more electrolytes, right? Like some of it is that we're peeing it off like crazy, but so much of rehab is really getting people on board with taking a ton of electrolytes. And through my almost decade of this, like even when I'm like, I've reached my capacity, that's plenty of electrolytes, I'm getting enough, and then I add more and I'm like, oh, I guess it could be better, right? Like you're like, that's a crazy amount, like I shouldn't be doing, like I used to do I think like 2, maybe 3 doses of electrolytes, and I'm talking like over 800 milligrams of sodium per dose.
With how many milligrams?
And I can do more than that.
Wow.
Like, so yeah,
Wow.
like I have patients that are hydrating plenty. Like they're like, I drink a ton of water. I have a guy right now that drinks so much water. And I was like, please add electrolytes. And he's like, I got water. It's fine. I'm like,
Is there a particular electrolyte that you like emergency or?
yeah. So I would say I really like Relight. That's more like a natural salt. It's called RE-LYTE. So they have flavored ones. They technically have stevia in them, but they have an unflavored one. It does taste salty, but it is like actual salt versus like sodium chloride. If you want another unflavored, Enact is great, like EN Enact. And that one is about 600 milligrams of sodium, and it has nothing else added in it. It used to be with honey, now it has cane sugar, so at least it doesn't have any stevia in it. We do need a little bit of sugar to actually get electrolytes into our body, so I wish most of them had regular sugar in it. But and then I like Vitacium. Those are capsules, so if people can tolerate capsules. Salt Stick is like the chewable ones. They make a chewable one. Those ones don't have as much sodium, but they're fast acting, so if somebody's like really in a bad place, it gets into their body quickly, so I usually have them pair like a chewable with a Vitacium like capsule. But
What do you think of emergency? Just 'cause I know I have it at home.
yeah, I don't know what the electrolytes look like on emergency specifically, but I know I try to avoid any of the ones, like Liquid IV can be okay, but there's an energy one, and I think emergency is similar where they'll have B vitamins in them, and a lot of patients that have these things have an MTHFR variant. And so the people in the room, if you don't know what an MTHFR variant is, it's a genetic change that makes it so you don't process B vitamins as well. And so some of my patients, I'm literally educating them on like avoiding the enriched and fortified foods, in case that's something that people aren't aware of. We spray food with folic acid, synthetic folic acid, which is the fortified. And I literally had a patient come in the other day and she was like, I get migraines when I have that fortified, enriched flour. And I was like,
Yep.
I'm glad that you figured that out on your own. This is probably what's happening. So yeah, if they can avoid those B ones. And so, I mean, I have the ones that I recommend, but yeah, if somebody can find one, I usually just say try to find one that has the right combo and then doesn't have any B.
Is that also a methylation issue?
Yes, correct. Yeah. So like if they have that, they just need a methylated B for their supplements. But also like if you have an overabundance of B that you can't utilize, like people can get agitated, they can get anxiety, they'll feel yucky, like their body's going to feel kind of clogged up if they're not able to process it. Yeah.
That's usually with the non-methylated.
Yes, yes. So
Whether you are an MTHFR SNP problem or not, across the board, just get rid of that other junk.
yes, correct. Like I would love if we could just take that out. Yeah.
Sounds like it also has a lot to do with insulin resistance too.
Yeah, so I mean, there's a huge hormonal component too. Like there's definitely a bigger incidence in endometriosis and POTS, and EDS as well, and then PCOS as well. Those are both going to be bigger, and then we know the insulin piece to that. But in general, just blood sugar regulation as much as every other autonomic function isn't regulated as well. So I do sometimes recommend people do like small bouts of berberine because that can be something that can help mitigate a little bit. But a lot of it is mitigating like how much sugar they're putting in their body and making sure that they're balancing it with protein and fat if they can. Eventually, at some point, most of us will be able to tell you, like, if I eat a little bit too much sugar, immediately I will tell you. I can't have it. Like I get immediate head pain when I get past a little threshold. So your body will give you some feedback in that, but yeah, there's definitely an insulin component. Great questions. Anybody else? Or did we catch it all? Cool. Thank you so much for your attention. This is great. Yeah.
Maybe a group photo.
Yeah.